Thank you. Can you hear me? Okay, sorry, my voice has been croaky for a while. So this is a paper in collaboration with a colleague of mine in Poland at the University of Lodz, Krystyna Dzwonkowska-Godula, and I know I haven't done justice to the pronunciation of her name. So I'll begin by thanking the organizers. I know you've worked so hard, the chair and my fellow panelists. So as international and domestic borders began closing in March 2020 in response to the COVID-19 pandemic, reproductive justice activists everywhere raised concerns about barriers to abortion access. And top of the list was cross-border travel to an abortion provider, which could be hampered by enforced quarantines, travel bans, flight and rail interruptions, and border shutdowns. So the pandemic effectively drew attention to a very commonplace but understudied phenomenon, and that is travel across international and domestic borders to access abortion services. And this occurs when abortion access is illegal or legal, but restricted, unavailable, or inaccessible, and it often involves traveling long distances from place of residence. So what follows is a comparison overview between the chronological trajectory of abortion provision in two countries, Canada and Poland, to show how legislative changes and the fallout of these changes drive cross-border abortion travel and how grassroots groups and NGOs have responded. So Poland now boasts some of the strictest anti-abortion laws in Europe. And ironically, Polish abortion laws were once among the most progressive in the world. So for example, between 1956 and 1959, now we're talking about post-war socialist Poland, which was then an Eastern Bloc member country aligned with the Soviet Union, permitted abortion on request due to socioeconomic difficulties. However, in the 1980s, anti-abortion sentiment rose alongside anti-Soviet resistance, allied with the Catholic Church to mobilize a very powerful anti-abortion movement. This is a fascinating part of the history, and it's too long to get into now. In 1993, the Polish government passed a Family Planning and Fetal Protection Act, and this limited access to legal abortion and removed the socioeconomic indication. So the number of officially recorded abortions plummeted by the thousands. This legislation spurred the growth of an abortion underground that provided illegal abortions for high prices, and it also encouraged travel to neighboring countries like Lithuania or Ukraine for abortion services, or further afield to more expensive clinics in the Netherlands or in Great Britain. These legal changes understandably entrenched socioeconomic and cultural inequalities. So poor women and young women and migrants and rural women faced financial barriers, especially if traveling abroad. And they also faced limited access to computer and internet services and a lack of knowledge of foreign languages. So in Canada, abortion was illegal until 1969, when the federal government introduced an omnibus bill, and this bill legalized abortion, it decriminalized contraception, and it legalized homosexual acts between consenting adults. And these significant legislative changes were supposed to signal the emergence of a new kind of Canada that was modern and pluralistic and secular. Now, before the passage of this 1969 law, women seeking abortions had very little choice but to bring the pregnancy to term or to seek out illegal abortion providers or to attempt their own DIY, that's do-it-yourself abortion, or travel to countries like Great Britain for legal abortion services. Now, the 1969 abortion law in Canada was intended to alleviate the problem of illegal abortion, but in practice, it was extremely obstructive. So assisted by grassroots student groups, feminist coalitions, and pro-choice organizations, Canadian women continued to travel overseas for abortions. And after some American states like New York legalized abortion, many more headed south of the border. And these journeys also spoke to race and class privilege in accessing abortion services outside the country, an issue that grassroots groups and NGOs highlighted very strongly as central to the law's unworkability and unfairness. Now, once the American Supreme Court ruled in the 1973 decision Roe v. Wade, that abortion was a constitutionally protected right in the USA, even more Canadian women headed south. So the 1969 abortion law galvanized women's liberation groups like the Vancouver Women's Caucus and NGOs like the Canadian Abortion Rights Action League, as well as physicians and clergy and lay persons and even some politicians to campaign for its repeal. And these energies coalesced around a pro-choice movement supporting Dr. Henry Morgentaler, who was Polish-born, a Canadian family physician and also a Holocaust survivor. And he first performed abortions in his Montreal clinic in contravention of the law. Now, in 1977, there was a report into the functioning of the 1969 law. And this report confirmed that because only 20% of hospitals across Canada were offering abortion services under this new law, abortion referrals across the border boomed. So between 1970 and 1975, an estimated 16 to 24% of Canadian women who had abortions had them in the USA. In 1988, following years of bruising legal battles, the Supreme Court of Canada struck down the 1969 law in a case known as R.V. Morgentaler, ruling that it violated women's charter rights to security of the person. So since then, Canada is one of the very few nations in the world that does not have a federal abortion law. In the 1990s, the anti-abortion movement flourished, and American anti-abortion violence spilled northward. Morgentaler's Toronto abortion clinic was firebombed in 1992, and later in the decade, 3 Canadian abortion providers across the country were shot and wounded. They survived. Politicians from various political parties introduced into Parliament dozens of private members' bills and motions beginning in 1987 and well into the 1990s and 2000s to restrict or ban abortions, but these measures have been unsuccessful thus far. So without a federal law governing abortion, the administration of abortion services came under the jurisdiction of individual provinces and territories, resulting in what one journalist called a patchwork quilt with many holes. So disparities in abortion provision became apparent, and an important study of hospital abortion access conducted for the NGO Canadians for Choice in 2006 showed that only 15% of hospitals were providing abortion services, lower than the 1977 figure of 20%. So this drop may have had to do with the growth of clinic abortions in some urban centers, but it was likely also due to the many barriers to abortion access that the study identified. And the barriers included the costs of travel and expenses related to accessing abortion services outside a pregnant woman's residential area. And then in 2013, another study that focused specifically on travel to abortion clinics confirmed that abortion services for women living in or close to urban centers were easy to access, but for those in Eastern Canada, rural areas, and Northern Canada, they were underserviced, sometimes necessitating long journeys to an abortion clinic, and significantly younger women and poorer women traveled the greatest distances. Now, in case you're wondering, medication or medical abortion via an abortion pill became available in Canada only after 2015, much later than in other countries. And while some provinces and territories cover the cost of the abortion pill in their healthcare plans, many others do not. So back to Poland. In Poland, dissatisfaction with the 1993 legislation, this is the Fetal Protection and Family Planning Act, encouraged Polish church-backed conservative politicians to try to ban abortion altogether, especially once the right-wing Law and Justice Party was elected to a majority government in 2015. The party's populist, nationalist, and pro-natalist ideologies are manifested in its opposition to immigrants, sex education, contraception, homosexuality, and abortion. Proposed anti-abortion bills that crack down on abortion, even to the extent of criminalizing women seeking abortion, animated mass resistance in the form of large and widespread protests, petitions, and strikes. An international network of groups and NGOs lobbying to loosen legal restrictions on abortion emerged to help Polish women. A ship with a mobile abortion clinic chartered by Women on Waves, an organization founded by Dutch physician Rebecca Gompertz, sailed to international waters off the coast of Poland in 2003. Polish Women on Web, a website based on Women on Web, also founded by Gompertz as an international online abortion service, disseminated information about medical abortion in Polish in 2006 on the internet. Women on Waves next collaborated with Polish women's groups to deliver packages of abortion pills by drone from Germany to Poland. In 2019, Polish Women on Web joined with Polish and international organizations to form an NGO called Abortion Without Borders. This NGO provides Polish women with information about surgical and medical abortion options, assists them financially and logistically with travel to another country for an abortion, and supports a telephone hotline. In 2020, Poland's Constitutional Court determined that abortion based on the indication of fetal anomalies was unconstitutional. And this ruling, which went into effect in January 2021, also penalizes those who perform abortions and those who assist women seeking abortions, and it's led to a near total ban on abortion. So the criminalizing of abortion in Poland has had a chilling effect, with many physicians often refusing to perform abortions. And Poland, a member of the European Union, has come under EU pressure regarding its stance on abortion. So a year ago, the EU Parliament requested member states, and I'm quoting here, to cooperate more effectively to facilitate cross-border access to abortion, for example, by granting Polish women access to a free and safe abortion in other national healthcare systems. So in Canada, managing abortion services during the COVID-19 pandemic posed evident difficulties, and these difficulties were tracked by NGOs like Action Canada for Sexual Health and Rights and Abortion Rights Coalition of Canada. However, there have been some positive outcomes. So a recent study indicated that a majority of medical personnel providing abortion care during the pandemic considered surgical and medical abortion essential to medical care. They were able to transition quickly to online consultations with patients, and they increased access to medication abortion. So this kind of healthcare delivery could potentially reduce regional variation in abortion provision. And then there's new federal criminal code amendments that now supposedly shield healthcare workers and facilities from abuse by anti-vaccine protesters. And this may now boost various provincial bubble zone laws intended to protect abortion clinics or hospitals providing abortion services, or even pharmacies dispensing the abortion pill from anti-abortion harassment. In addition, the federal government's 2021 budget under openly pro-choice Prime Minister Justin Trudeau earmarked $45 million over 3 years for community-based organizations providing sexual and reproductive health care, information and services to vulnerable populations, including travel and logistical support to individuals who have to go long distances to access abortion care. So during the COVID-19 pandemic, Polish women's access to abortion services was circumscribed by periodic border closures, preventing travel to abortion clinics in other countries. Abortion Without Borders noted on its webpage, coronavirus is simply yet another obstacle faced by people living in countries with inadequate provision of abortion services. And after Russia attacked Ukraine in early 2022, the massive influx of Ukrainian refugees into Poland posed an additional challenge, including by those who had been raped and impregnated by Russian soldiers. So several Polish and international organizations immediately prepared information in various languages about the possibilities of reproductive health care in Poland. And in 2022, the French government provided 60,000 euros to Abortion Without Borders in support of Ukrainian refugees in terminating pregnancies. So, to the conclusion. Shortly before the American Supreme Court overturned Roe v. Wade in the summer of 2022, the executive director of Women on Web remarked with no small irony, many American women will have to do what Polish women are already doing to get safe abortions. And Karina Gould, Canadian Minister of Families, Children, and Social Development, even announced that Americans would be able to obtain abortion services north of the border. These comments recognize the significance of cross-border abortion travel when abortion is illegal or otherwise difficult to access. In the case of Poland, the government has perversely been able to tighten its anti-abortion laws over the years because international cross-border abortion travel, in addition to the abortion underground, has served as a really convenient pressure release valve. In Canada, functioning without a federal abortion law on the books since 1988, domestic abortion travel serves as a stopgap measure that allows federal, provincial, and territorial governments to ignore their many shortcomings in providing legal and equitable reproductive health care delivery across the country. In the similar and dissimilar experiences of both Poland and Canada, it is obvious that grassroots groups and NGOs facilitating abortion travel internationally and domestically are the unsung heroes of this history. Running on a combination of dedication, moxie, and innovation, they have picked up the slack for national healthcare systems that continue to fail women in fundamental ways. The COVID-19 pandemic and the bleak post-Roe v. Wade abortion landscape in the USA should cast a spotlight on the necessity of integrating fair and equitable reproductive healthcare strategies across borders and healthcare systems into the DNA of law and medicine. Thank you so much for your attention.
Thank you. Thank you. Thank you very much. Wonderful. And now let's hear from on borders drawn across bodies, advocating for maternal health in times of crisis. It's Sarah Lazin, who's a LL.M candidate here at University of Ottawa. Welcome.
Thank you. I should have slides. I'm just going to wait for it. Is it just this one here? Oh, perfect. I'll just slide a wee bit closer then. Okay, perfect. Oh man, I'm not funny enough to have a joke prepared. While we're waiting for the slides, I'll just introduce myself. So my name is Sarah Lazin, and I'm a master's candidate here at the University of Ottawa. Before I begin, I do want to thank the conference organizers for including me in this event. It's an incredible opportunity as a master's student to be given this kind of platform to speak on a topic that I am incredibly passionate about. And that would have been my segue into my slide.
And this is not a great introduction when your slides are not even there. Adds a bit of stress, but there we go.
Right.
Here we are.
Beautiful. Hoping they'll appear here so I don't have to look behind me as well. But as you can see, my presentation is titled Borders Drawn Across Bodies, Advocating for Maternal Health in Times of Crisis. So in raising this topic, I'm going to take a much more flexible definition of borders than what we've seen so far this weekend. Rather than looking at borders drawn between lands, I'm more interested in borders drawn between bodies. To provide a quick overview in what I'm going to be talking about today, I have divided my research into two broad categories. So barriers to COVID vaccines and barriers to community and to care during the pandemic. While much could be said about all of these topics that you see in front of you, my goal for this afternoon is to provide you with a brief overview of how maternal and reproductive health has been uniquely impacted by the pandemic itself and by the public health measures taken during the pandemic. My little button has stopped working. In the interest of time, I'm just going to keep chatting so we don't run too far over. So I'm going to begin with a brief overview of maternal health in the context of COVID. Quite frankly, for as long as there have been pandemics, women have been disproportionately impacted. It is evident throughout, it became evident rather almost immediately during COVID that this trend would continue, from increased duties of care in the home, to increased rates of domestic violence in the early days of the lockdowns, it was immediately obvious to everyone that women were going to be disproportionately impacted by this pandemic as well. In terms of clinical outcomes, pregnant women who contract COVID are 5 times more likely to be admitted to the hospital and 10 times more likely to be admitted to the ICU than their non-pregnant counterparts. There are also much higher rates of preterm birth amongst pregnant women who have COVID, which poses additional risks to both mother and to child. Of those infants carried to term by a COVID-positive mother, nearly 10% are subsequently admitted to the NICU. There has been a small but still noted rate of pregnancy loss, approximately 2%, and the high fevers caused by COVID, and especially serious COVID infection, can raise the risk of birth defects. In fact, COVID was the leading cause of maternal deaths in Colombia and in Mexico in 2021. And importantly, many countries are considered to be underreporting and undercounting maternal deaths from COVID, or simply not counting them at all, leading to detrimental gaps in our data and knowledge. So my next slide is exclusion from vaccine testing. So the first border that I want to draw attention to today is that separating pregnant women and the general public in terms of access to vaccine development and testing. This exclusion is not novel, it's not new, and it's not unique to COVID. Women of childbearing age, whether pregnant or not, have historically been excluded from virtually every type of clinical research due to ethical concerns as well as fears of potential liability should the mother, but more realistically, should the fetus be negatively impacted down the road. These concerns do have historical roots, so they're not unreasonable. In the 1950s and 60s, thousands of expectant mothers were prescribed thalidomide to treat their morning sickness. And this drug ended up causing severe congenital limb deformations amongst many of these infants after they were born, and resulted in the exclusion from pregnant women from participating in any experimental drug trials until the 90s. Fast forward to today, pharmaceutical companies continue to express low interest in developing maternal vaccines. It's estimated that only 1% of industry-sponsored studies are specifically designed for pregnant women. And the other 95%, I know that's not quite 100%, but 95% of phase 4 clinical trials explicitly exclude pregnant women. The effects of doing so are numerous. As I will discuss shortly, the lack of data surrounding pregnancy and drugs forces pregnant women and their healthcare providers to make ultimately or underinformed decisions without being fully aware of risk versus benefit. It's important to note here that many pregnant women do receive the seasonal influenza vaccine, despite the fact that they have never been specifically tested on pregnant women, nor are they licensed as maternal vaccines. And approximately half of pregnant women will use at least one prescription drug during their pregnancy, most, if not all of which, have never been tested on pregnant women. So ultimately, this exclusion leads to pregnant women, as well as their fetuses and newborns, who would receive the benefits of a COVID vaccine when they're too young to receive their own, from receiving the same benefits that everybody else gets. COVID vaccine research is underway now, finally, for pregnant women, but they were excluded from the development of COVID vaccines and testing well into 2021. This, in my opinion, mirrors the 2009 H1N1 vaccine testing that was carried out on pregnant women only after there were years of post-market data demonstrating that it was safe. So in this way, they're able to escape liability by saying, well, it's already happened out in the world, so it's probably safe to do it here, which is really backwards of the way that it should be. Importantly, mere perceptions of safety risks will exert a disproportionate effect on the willingness of pregnant women to seek vaccines. The lack of clinical data has led to extremely mixed messaging by governments and public health bodies. And while the vaccine is now widely recommended for pregnant women, this confusion has led to ongoing hesitancy and misinformation. Can I have my next slide? Now that we have slides. Oh. We're going to the inconsistent messaging slide, if anyone can hear me. As I'm sure.
So it appears that the people online cannot see the slides, so let's assume that it's difficult for them to.
It was just a background for you guys to look at, so it's really not that important. As I'm sure we are all aware, we have all received many different and often competing ideas of what is best to do throughout the pandemic, when to get vaccinated.
The button on the bottom. That's like, yeah. There you go.
Huzzah! Here we go. When to get vaccinated, which vaccine brands are best, whether masking is effective. This is true too of messaging directed at pregnant women. So for example, on January 7th of last year, the CDC recommended that vaccination against COVID during pregnancy should be an individual decision. The next day, the World Health Organization recommended against vaccination during pregnancy, unless the scales were tipped vastly in support of benefit against risk. So for example, healthcare workers or those with comorbidities linked to severe COVID infection. So this warning by the World Health Organization was specifically directed towards the Pfizer vaccine, and it took another 2 full weeks for the WHO to make any sort of recommendation about Moderna use during pregnancy. With no clear health messaging in sight, vaccine centers across Canada began to turn away pregnant and breastfeeding women, citing, you guessed it, a lack of clinical data. At the same time, the government of Quebec took the stance that vaccinating pregnant women would come in time, requiring further studies into this group. So in doing so, provincial governments barred pregnant women from making autonomous healthcare decisions rather than letting them decide for themselves whether vaccination was appropriate, and few, if any, other competent adult patient groups were treated this way. To confuse matters further, across the country, the official recommendation coming from BC was that pregnant women should work with their healthcare providers to make informed decisions due to their own circumstances. It is deeply problematic, but not unusual to Canada, that pregnant women in one province were barred from accessing care, in this case vaccines, while those across the country had the option to exercise their autonomy. As a little aside, pregnant women were not eligible for the COVID vaccine in Quebec until April 2021, nearly 18 months into the pandemic. At the risk of stating the obvious, this is twice the length of a normal pregnancy, meaning that many women would have spent their entire pregnancies without any type of protection against COVID, and well over 100,000 babies would have been born in Quebec during this time. Tied to inconsistent information is misinformation. Now, COVID vaccines are widely recommended for use during pregnancy, but pregnant women continue to make up an alarming number of hospital and ICU admissions, virtually all of whom are unvaccinated. The rumors relating to COVID online have included infertility, miscarriages, and harm to the fetus. All of these rumors have been scientifically disproven, but fear and social media are perhaps more persuasive to many people. In this way, the pandemic has pointed out 2 major gaps in our response to the misinformation epidemic. First, many of the rumors surrounding infertility and miscarriage seem to stem from reports in changes in menstrual cycles following vaccination. By September of last year, over 30,000 reports linked to menstrual changes following the vaccine were reported in the UK alone. It's thought that these changes are due to a link between immunological responses and hormones, but of course they're understudied and underreported. By failing to research and report on women's health, we leave more space online for clickbait articles to come to their own conclusions, which ties into the second main gap, which is the speed and access of good quality, accurate research. It can take months, if not years, to research, submit, and publish data, but misinformation can be shared in seconds. So if access to information is delayed, written only in medical or legal jargon, or hidden behind paywalls, we are essentially abandoning the general public to come to their own conclusions. The second part of my presentation, which is well after the halfway mark, I'm going to shift quickly to discussing borders drawn between women and their access to reproductive health care. In the spring of 2021, fertility clinics in Canada began to close their doors. In Ontario specifically, there was a provincial directive put out to pause any non-urgent and non-emergent procedures. This directive was left deliberately vague so that each specialty could describe or classify procedures according to their own parameters. And the pause obviously served 2 purposes. It was to reduce risk of COVID transmission in clinical settings and to alleviate the stress on healthcare workers. Fertility societies, across Canada, the US, and Europe have all classified fertility care as essential. But there's a really tricky and sticky classification in essential versus emergent and urgent. I think it's fairly clear how abortion care, for example, would fall under urgent. It's not really something that you can wait on, but it becomes a lot harder to define for families who are trying to conceive. So while not as life or limb as other types of healthcare, the inability to access fertility care, especially when facing months-long disruptions, caused tremendous emotional and psychological as well as financial harm to a lot of patients. In one study, nearly 25% of patients surveyed by the American Society for Reproductive Medicine described the loss of a cycle akin to the loss of a child. Furthermore, many patients pursuing fertility care are already at an advanced reproductive age, adding to the relative urgency of their procedures. Patients who are at an advanced reproductive age or who have lower financial resources available to them and who have already committed to treatment in some way were the least likely to accept that fertility treatment was something that could be indefinitely postponed. Importantly, of those patients surveyed, many, if not most, understood the necessity of closing clinics. They weren't asking to be treated completely differently. They weren't asking for special treatment. Their concerns largely centered on, first, the lack of clear information, timelines, and next steps, and second, the lack of consideration paid at all to fertility patients. Could it not have been possible, for example, to allow women to finish an egg retrieval or an IVF cycle without allowing other patients to then begin new cycles? No, we're doing so well. In my last couple of moments, I do want to speak briefly to the impacts of social isolation on birth and maternal health outcomes. In another attempt to limit the clinical transmission of COVID, many hospitals imposed restrictions on how many visitors pregnant women could have prior to, during, thank you, Giles, and following labor. This is particularly true of COVID positive women who were often denied any visitors at all. In fact, COVID positive women were 11 times more likely to be denied a support person during labor than those uninfected. COVID positive women also were far more likely to be separated from their newborns almost immediately, contributing to immense stress. I can only imagine how traumatizing such separation would be, especially for, say, Indigenous women who have good reason to be fearful of hospitals separating them from their children. Similarly, more research is needed into the stress and trauma experienced by women, those who didn't have support people available to them, with a focus on women, for example, with low literacy, health literacy, who may not feel comfortable or safe in clinical settings, and on women from rural and Indigenous communities who had to come into urban centers to give birth, thus abandoning their broader social and cultural supports. Social isolation during childbirth is thought to increase the risk of maternal morbidity. COVID positive women who were denied visitors were 6 times more likely to report acute stress symptoms during their birthing experience than those allowed visitors. Denying women a support person during labor is also linked to greater pain in delivery, newborns with lower birth weights, elevated NICU admission rates, and increased maternal mental illness during the postpartum period, all of which are things that we should be taking active steps to avoiding. Thus, it does not appear that the correct balance was struck in mitigating risk by isolating women during childbirth. In taking a quick moment to conclude, I hope I have demonstrated the extent to which further research and consideration is needed on the unique positionality of women, and particularly on pregnant women during this and future pandemics. Thank you.
Thank you. Thank you so much for a great presentation, despite all the challenges. Thank you. It's wonderful. So let's hear now from Jason Nickerson, who is the humanitarian representative to Canada, Doctors Without Borders. You can stand, good. And he's going to keep it light enough to travel the heavy burden of COVID border restrictions on humanitarian assistance. Thank you, Jason.
Thanks. Oh, it's even on. Okay. I think we're going to have slides. Otherwise, it's going to be jazz. Thanks very much. So I'm Jason Nickerson. I'm the humanitarian representative to Canada for Doctors Without Borders, and also an adjunct professor here at the Center for Health Law Policy and Ethics, and an investigator at Briere. So here it comes. I'm going to give you a bit of an overview of our experience as a medical humanitarian organization during the pandemic. Very much going to focus inward on our experience organizationally, navigating some of the challenges of closed borders, of travel restrictions, and so on. I know there's other people who've done a tremendous job of talking about the experience of people trying to access healthcare and so on. I think from the perspective of an organization responsible for delivering healthcare, there's also a bit of an untold story here, because the world became immensely complicated for us in very short notice. I do have slides. All right, I'm just going to talk. You're getting the free jazz version. Look, we're a humanitarian organization that works in about 70 different countries around the world that are mostly affected by various kinds of crises, everything from armed conflicts to forced displacements to disease epidemics and natural disasters. We're one of the largest humanitarian organizations in the world. Last year, we provided about 12.5 million outpatient consultations. We admitted about 1 million people to hospital. We're one of the largest, we're actually the largest non-governmental provider of tuberculosis care in the world, and so on. So as I say, we work in about 70 different countries. That translates into about 460 to 475 individual projects that range from anything from community-based public health programming, so sort of sensitization and health education, through to primary, secondary healthcare, as well as more actually quite complex tertiary care in certain contexts, which can include fairly advanced surgical interventions and so on. In many places, we're the provider of last resort. We're an organization that invests very heavily in our ability to negotiate access and to negotiate our acceptance across front lines in very rural and remote parts of the world. And it's a model of care that's premised on an understanding of an international legal framework, so predominantly international humanitarian law. But also, is very embedded in the communities with whom we work and who we provide care to. 80% of our staff, which is anywhere from sort of 45 to 60,000 people, about 80 to 90% of our staff are local health professionals, administrative professionals, and so on. But we do have a relatively large international workforce as well that does need to continue to travel to reach, as I say, people affected by crises. The pandemic, of course, made that much more complex, but it didn't change the reality that we as an organization needed to continue to provide emergency and essential care to people affected by crises. And that meant that we had to continue to send people to the field. It meant that we had to continue to find ways of navigating border closures to enable our staff, who are often quite specialized technical staff, to be able to reach our medical projects. And so the people that we're often sending to the field to our projects in our international workforce, in many cases are highly specialized people. So these can be emergency managers, they might be medical specialists, they can be nurse activity managers, and so on, as well as logistics staff, financial coordinators, and so on. Anybody that you would conceivably need to bring a specialized expertise to a medical project, we often have to move people around. So in March 2020, there we go. Now we're cooking. Now the real question is this going to work? No. Can I have the next slide? Somebody. Okay, so yeah, sure. I can keep pushing it and we'll see what happens, but that's okay. We're fine. As they say, you're just getting the free jazz version. So March 2020, the world shut down, I think, as we all know. countries moved relatively quickly to attempt to essentially hermetically seal themselves off from one another. And so in a normal year, in a normal month rather, we would send normally 600 staff through international placements to try and reach our projects. So by April, that had declined to somewhere around 150. All right. And so on. So we saw a real steep reduction in the number of staff, and the numbers are on the next slide. But I think that it's clear that what we saw initially from countries was an attempt to, as I say, hermetically seal themselves off. But very quickly, countries realized that this is actually a bad idea, because no individual country has all of the resources that they need to be able to respond to the COVID pandemic. So international medical supply chains are international, of course, and indeed many countries rely on an international health workforce, including, Canada and the US. We saw sort of at the Ontario border, there's a number of health professionals, right, that go across the border on a day-to-day basis in either direction. Can we go? All right, thanks everybody. How do I go? We're all over the place, but we're good. All right, I am in control of the remote. So what we saw was that as countries implemented some of these border control restrictions, they disrupted this entire process. I think it's important to recognize that this was obviously an overshoot, and many countries realized this, but some of this was also deliberate. So one of the challenges that we encountered is that, so we maintain our own international supply chains. So we have stockpiles of emergency equipment. Much of it is based in European supply centers, so we do have logistics bases and warehouses in East Africa, as well as in Dubai. So what we did see was, as countries closed their borders to attempt to limit the movement of PPE, as well as pharmaceuticals and some medical supplies, we were not initially exempted from this. So we also experienced significant disruptions in our own supply chains. Many of those border closures eventually, and actually fairly quickly, to be fair, exempted humanitarian organizations, which allowed us to continue to move things out of our warehouses. But we were not immune from, the sort of global scramble to acquire PPE and other medical services. So our supply chains actually became very acutely disrupted, as well as our ability to move people from place to place as a result of the border closures, which initially were extremely complex, and I'll talk about that in a second. But it really took us more than a year, to be honest, to sort of reestablish a good cadence to the PPE and sort of the medical entrance that we required, because we don't depend on donations. We actually rely on negotiating with suppliers to obtain fair and affordable prices for the supplies that we need. And of course, April 2020, it was just ridiculous, quite frankly. And so it was very difficult for us to get the supplies that we needed. Okay, so the border restrictions were actually incredibly varied and really quite complex. So we move people from, many different countries to many different countries. In the initial days of trying to understand this, certain people could go to certain places. You had different quarantine periods. People could move sort of inside and outside of different parts of airports and so on. And it became, very, very disruptive. So this is the statistic that I was talking about. Sort of pre-COVID, we were moving about 650 staff from one location to another. We saw that immediately decline in April of 2020 down to 114 and then 202 in May. So a real significant disruption. I think it's important to note that this challenged us as well to question our reliance on international staff. There's a variety of reasons, as I say, why we have international staff present in our projects. A lot of it is related to quality of care and so on. And we typically don't do what we would call remote management. But during the pandemic, that challenged some of the assumptions that we had been making as an organization about how much can actually be done through, sort of remote management and telemedicine and so on. So there were sort of net benefits to that, I think, in sort of questioning and challenging some of these assumptions. But a large contribution to the decline in the number of staff that we sent was due to the collapse of the international commercial flight availability, which we rely on very heavily. So by May 2020, about 50% of all of the United Nations Humanitarian Air Services flights were made up of MSF staff. We made use of different air hubs and so on that were established because humanitarians, of course, needed to continue to move around the world. We did also manage to negotiate for some of our staff to be on board of government repatriation flights. Our people were going in on essentially empty planes as governments were chartering flights to bring citizens out. So we got creative, but it was a very complex time. From a Canada perspective, so March 2020, we of course saw the first orders in council that were brought in, which effectively, sealed Canada to any non-citizens. There were a small number of criteria that established, the non-application of that initial order. Humanitarians were not included in that, and in fact, never were specifically exempted from Canadian border restrictions. We saw that as those orders came in, they were set to expire at regular intervals. I forget what it was, 60 or 90 days or something. And the exemption criteria or the non-applicability criteria from Canadian border laws gradually expanded to include everybody from high performance athletes and hockey players to medical couriers to airplane staff and so on. But as I say, never once included an exemption for humanitarian workers who, of course, continued to travel and who needed to continue to travel as part of the global public health response and attempt to control the pandemic. And then, of course, it became more complicated with the imposition of hotel quarantines, PCR testing, and so on. So just to speak a little bit to that, our travel is logistically complex. It's not inconceivable that somebody who is working in one of our projects could be in a rural part of Central African Republic, so Sudan, Yemen, in any number of crisis-affected places. So reaching an international flight typically means that somebody has to come from a hospital in a rural part of the country to reach a capital, to get on an international flight that typically takes them to another hub, and then they return to Canada. So there's a number of different steps in that. And, it's actually not that unusual that somebody coming from a rural project somewhere may have to take, drive to a boat to reach an airstrip to get on an internal flight to reach the capital. They spend the night in the capital, they get on the international flight, and then they take their connections and so on. So at the best of times, it's logistically complicated what we do. And that actually made it very difficult, if not impossible, to comply with some of the requirements in the Canadian border restrictions. Can I have like 1 extra minute to account for the technical stuff? Okay. And so, this made it very, very difficult for us to comply with the hotel quarantine requirements, because the hotels could actually only be booked 48 hours in advance. We had to prepay for 72 hours. So that 48-hour window, our staff are routinely disrupted 48 hours. And Wendy, as our former national president, can speak to the numbers of times that one of our staff might get delayed because the boat is late or the plane has to medevac somebody instead of a passenger. Or, there's a number of different things that can result in disruptions 48 hours before somebody needs to get an international flight. Meant that it was very difficult for us to actually book these in a window of time. And then it actually became very expensive because if we didn't use the full 72 hours, it was at the hotel's discretion as to whether they would be refunded or not. So, it was difficult for us to comply, and it became very expensive for us as well. More pragmatically speaking, we do transit staff through Canada fairly regularly, mostly to reach Haiti as well as Central and South America. And a non-Canadian citizen was not allowed to enter Canada for the purposes of transiting for the majority of the time where these restrictive measures were in place. They were allowed to stay in what's called the sterile part of the airport, But because of the sort of collapse of the commercial airline industry, that often meant that our staff would be transiting through Canada for a period of 48 to 72 hours. Asking somebody to sleep in an airport terminal for 48 to 72 hours during a respiratory pandemic is also not the right public health move. But they weren't actually allowed to leave the sterile part of the airport to go directly to a hotel and then back, because that would be considered entering Canada, and they would have had to quarantine for 14 days at any sort of given point. So at this point, these border restrictions actually became quite an interference for us to be able to transit staff from European locations through Canada to reach Haiti in particular, because there is frequently a direct flight from Montreal to Port-au-Prince twice a week. But we simply ran out of options at different points in the pandemic. I think I've exacerbated my 1 minute of generosity. So I'm just going to conclude by saying, the overarching message here is that during times of crisis, we need to continue to move our personnel. We need to continue to move our supplies. And unfortunately, we and other humanitarian organizations were largely an afterthought and not considered in the drafting of these restrictive border measures, not only in Canada, but in the majority of countries around the world. And that led to significant gaps in staffing, as well as holdups at customs and in other places. Canada does have legal obligations, as well as I would say a moral and ethical obligation to ensure that they're not directly or indirectly interfering with the provision of humanitarian assistance. But we've seen that there's actually a number of different Canadian laws that are currently in place. I would say most notably Section 83 of the Criminal Code, which is a completely separate issue, but relates to Anti-Terrorism Act, which is currently interfering with Canadian NGOs' abilities to work in Afghanistan. But the overarching message is that what we're seeing is, as Canada implements different restrictive measures, they're not considering the potential impacts on humanitarian organizations, and that is having very significant and very real impacts on our ability to work. So happy to answer questions. Thanks.
Let me now invite to the podium Adam Houston is also with where you live should determine whether you live, the line between rhetoric and reality in global COVID-19 vaccine access. Thank you, Adam.
Right. Yes, thank you. I'll wait for my slides because I'm not very resilient or jazz oriented. I will get into this in a second as soon as it switches over. But Colleen originally asked me to speak about the International Sanitary Conference of 1851, which I do like talking about. But, I decided that COVID-19 vaccine equity was a bit more topical. But, we do have 29 countries with cholera this year. WHO has just announced a cholera vaccine shortage, and this is before one of the 2 vaccines that's used in cholera outbreaks is discontinued at the end of this year. So, these are ongoing issues. All right, here we go. Maybe, what am I pointing at? Is it doing things? Oh, okay. Vaccine equity. Again, as mentioned, I am with MSF, so that's my conflict of interest in case anybody notes my subtle bias towards access to medicines. Vaccine equity is very important for a lot of the things we talked about at this conference, right? If we are talking about vaccine requirements to cross borders, having access to vaccines is very important. It dictates, people from which countries are going to be able to cross borders. And we can look at the layers of which countries didn't have access to vaccines and which countries already face more restrictions on their travel. Similarly, domestically, you want to have vaccine mandates, you want to have vaccine passports. A prerequisite to those things is having vaccines to mandate. So if some countries didn't even have the option to have some of these discussions. But of course, at the very beginning, the international community looked like it was very keen on the idea of vaccine equity. So just a delay when I do this. Unfortunately, in practice, that is not at all what happened. So when we're talking about this gap between rhetoric and reality, a very key example here that we can use, that I will use, is Canada. So, shortly after this op-ed with many world leaders, Canada embarked on a purchasing spree that led to Canada securing the most doses, quite notoriously, the most doses per capita of any country in the world. So this is, 429 million doses through bilateral contracts for 38 million people. Other wealthy countries were doing similar things, though not quite that many doses. Problem is that this meant when the mechanism that was intended to ensure vaccine equity, the COVAX facility, went to get vaccines, the cupboard was largely bare because all the vaccines had already been claimed. So when we get then, the WHO calling for rich countries and vaccine firms to stop these bilateral deals so that, the COVAX facility could actually access vaccines. Nonetheless, despite these calls, even well after these calls, Canada entered into yet another deal, its 8th, with the Serum Institute of India. In a pretty big flaw in the design of COVAX, COVAX was very heavily reliant on the Serum Institute of India to supply low and middle income countries. And that became very apparent once India closed its borders to export of vaccines. But before that happened, Canada was directly competing with the supply for low and middle income countries with this deal. While simultaneously also being one of the only wealthy countries to actually take vaccines from COVAX. Now, of course, to be clear, Canada had every legal right to do that. That is how COVAX was supposed to work. You buy in and you get vaccines out. How it wasn't supposed to work was to double dip like that. So and at the same time, yes, many of these countries, including Canada, were making financial contributions to COVAX, but financial contributions aren't as helpful when there aren't actually vaccines available to buy. So in the face of this, COVAX had to evolve. It then developed a vaccine donation mechanism, which had not been part of COVAX. It was not designed with an actual surplus dose mechanism. It's the head of COVAX. Ironically, though, Canada, the country that had secured the most doses per capita, and even more ironically, had actually specifically funded the creation of this COVAX donation mechanism, was very reticent to actually commit to sharing. Throughout the fall, multiple ministers, including the Prime Minister, repeatedly dodged the question of, will Canada share and when will that be? It wasn't until mid-December in an interview with Evan Solomon that the Prime Minister finally said, if Canada has excess COVID-19 vaccines, they absolutely will be shared. For the next 7 months, this if would do a lot of heavy lifting. As Canada entered into a paradigm that we might term Schrodinger's vaccine, in which the exact same vaccines from the exact same contracts had very different properties, depending whether they might be headed for Canadian arms or other people's. In the former case, they could be subject to forecasts, to schedules, and so on. But for the rest of the world, those doses remained hypothetical for many months. In fact, even at the G7, when Canada committed 100 million doses to COVAX, 0 of those 100 million doses, 0 were from Canada's bilateral contracts. They were a combination of Canada saying, okay, we won't take any more doses from COVAX, about 13 million, and not in kind, in cash equivalent of doses, which again, real questions about were there doses available to buy. Meanwhile, Canada was still doing things like accepting donations of vaccines, from the United States at a time when actually Canada had a better first dose rate than the US did, and at a time when many other countries in the world still had received 0 doses, where perhaps these could have been redirected to. It wasn't until mid-July of 2021 that Canada finally committed any doses from its bilateral contracts, in this case, 17.7 million doses of the AstraZeneca vaccine, which by this time was on the way out in Canada as a vaccine that would be used by Canadians. Just about 2 weeks after Canada finally committed to share some bilateral vaccines, Canada itself physically received enough vaccine to double dose every single person who was then eligible. In contrast to Canada physically receiving enough vaccine to double dose everyone then eligible, Canada's pledges demonstrated that, a shot in the arm is worth more than one in a press release. Canada didn't actually deliver any shots to COVAX until September. Some of those there were questions about them being on the cusp of expiry in Nigeria, for example. And throughout the fall, despite Mr. Anand saying that Canada would maintain a stockpile of 4 million doses in the central vaccine inventory, and then beyond that, there would be donations, the central vaccine inventory never actually dipped as low as 4. It was generally above 10 throughout the fall. Canada's now addressed this problem by simply not publishing how many doses are in the central vaccine inventory, which is perhaps not the best solution. So where are we now? Canada says that it's well on the way to meet what is now a 200 million dose pledge to COVAX by the end of 2022. Of that, 87 million doses are equivalent of doses. That number and how they get there is a bit shaky. What vaccines, where they went, what the status of those doses are also unaccounted for, still quite shaky. And 50 million doses of surplus, of which 22.4 million have been delivered. Most disturbing about this calculation is, so that 50 million of surplus doses, that includes 13.6 million doses of AstraZeneca. So that's 75% of a 17.7 million dose pledge that expired without going anywhere. Those were never delivered anywhere. So it's incredibly cynical to count over 13 million doses that never went anywhere, never helped anyone as counting towards Canada's pledge. Before I do that, so, on this note, yes, there are, supply is no longer the problem it was in 2021. That's true, but nonetheless, that doesn't really benefit the people who died because they couldn't get a vaccine a year ago. And of course, when we talk about the availability of vaccines globally, we're not talking about the bivalent vaccines that, I went as a Canadian and got last week, that are the new standard here. So again, we're seeing new gaps in equity. So, to say there are people, including, to be honest, some people who presented at this conference who described Canada's massive over-securing of vaccines as a global win. It was not a global win, to be clear. But the question also arises, why would we think that it would be beyond an aura of Canada's a good guy? Because on vaccine equity, we haven't been. Way back, H1N1, 2009, we were actually the odd ones out. We weren't sharing, so we were actually left out of an international arrangement to share doses. Similarly, monkeypox, the monkeypox vaccine, Canada has been stockpiling this vaccine for over a decade. Nonetheless, we have not seen Canada responding to calls from the WHO to share its supply of this vaccine. So when we come back to this gap between rhetoric and reality around vaccine equity, I haven't in the short talk, I haven't even got into the issue of Canada's role in making the pie bigger as it takes more than a very large slice. So I haven't talked about Canada's support for the status quo on IP at the WTO. I haven't talked about Canada's rather bizarre refusal to use the existing TRIPS flexibility that Canada itself has been the biggest proponent of using in opposition to the TRIPS waiver, yet Canada won't use it. And I haven't talked about Canada's disinterest in promoting tech transfer of Canadian developed technologies at public Canadian universities, like most prominently the lipid nanoparticle tech that underpins the mRNA vaccines that was developed at UBC. Canada has not shown interest in getting these Canadian innovations out to the world. And, relevant to some of the folks here, when the pandemic treaty negotiations involve discussions of things like access and equity, is Canada going to be perceived as the honest broker that it certainly likes to portray itself as? And just in closing, I think this Canada's, the gap again between rhetoric and reality is really underscored. This was in the budget of all things last year, where Canada's talking about a world-leading vaccine campaign, and it's emphasizing things like its world-leading first doses fast strategy, right? Get as many doses and as many first doses in as many arms as possible. Portrays this as world-leading. Unfortunately, Canada itself didn't seem willing to take the steps to extend first doses fast beyond its own borders. Thank you.
Thank you. Wonderful. So I think we've had a good overview of both almost the failure of your human rights framework to both look after specific groups that needed special care and both the women, humanitarian workers, and then the rest of the world needing transformative actions that was not forthcoming. So I think that sets us up well for the future studies and future work. There's time for question a little bit. So yes. And, do you mind coming to the mic?
My voice carries.
It might be for the people that are online, and we have a number of people online. Thanks.
It's difficult to address all the questions to all the speakers, but the last gentleman, is there a couple of questions here. Is there any accountability as to how the government of Canada said that it would contribute, it would share, it would donate to COVAX, and it hasn't, the 13.6 million doses of expired Zeneca that never was delivered? The United States, having donated 1 million doses to Canada, did it get paid for it, or was it donated? Why didn't it go somewhere else? Why to Canada? And thirdly, well, how do you address who takes accountability for all of this? Is there someone, aside from the Prime Minister, was it done to garner votes for the election, if you want to be totally cynical about it? Or what was the underlying reason? And one last question is, why did Canada have to amass so many doses, far more than Australia, almost 80–70% more than Australia, which had an internal lockdown between states as well? It's mind-boggling. Thank you.
Right. Yeah, no, some good questions there. And if my colleague, Dr. Nickerson, needs to jump in, he should as well, or anybody else. So yeah, there's a lot of big questions there. I wish I had an answer to the accountability question. I mean, now I'm in the super awkward position of like defending some Canadian things in responding. I mean, Canada has provided money, and and that money's been delivered. There's no real question that at least the majority of money Canada has pledged has been delivered, and Canada has reached higher benchmarks in terms of, proportion and so on than many other countries. There are, though, these questions of what the actual consequences of that money is. Again, if there's no doses to buy, especially early on, what does that mean? Similarly, in terms of so many doses, right? More than 11 doses per person. At the beginning, it's true. In fairness, we did not know that any of the vaccines would work. And as we see with COVAX, relying very heavily on one vaccine from one supplier, we saw the problems even when there was a working vaccine, we see the problems that arise there. So having a wide portfolio of vaccines that Canada was investing in, there's some logic to that. That's not necessarily a bad procurement strategy. The problem is when there's a limited supply and you're procuring over other folks, and then you're not sharing, right? This is going to the pizza parlor, ordering 11 pizzas, even though you're probably not going to finish 11. And even if you're saying to the guy number 12 behind you, hey, we'll spot you, but I'm not going to share any of the pizzas for myself, even though I won't finish them all. They're still going to be waiting for that 12th pizza for a long time. So, there's some justifications for some of it. But yeah, man, I wish I had answers, and I hope that maybe some people in this room will think about demanding answers in the future. Well, I mean, you might have to ask the Americans why they prioritized us. Well, we're their neighbors, borrowing a cup of sugar. We're the it's soft soft diplomacy.
Yeah, supply chain. Yeah. So question at the mic and then. Yes.
So my question is not about these papers. My question is addressed to the earlier papers in the panel, particularly the two women. And I want to preface my question by congratulating the conference organizers for making sure that women were not invisible in this discussion, because women are often invisible. In fact, there's a fantastic book called Invisible Women when we're talking about new technologies, for example. So that's yeah, congratulations. And of course, we expect nothing less from Colleen and the team here, but it is really great to see that. My question is this. Quite a lot of people in the room here are law professors, including me. So you've outlined some of the major discriminatory elements of what's been happening for women in the context of access to reproductive rights, in the context of access to medicines or healthcare or whatever. Is there anything that international law can do about this? For example, a convention on whatever it is, CEDAW, the women, the Women's Convention. That's my question. Is there anything that international law can do about this?
Can you hear me if I speak with my mask on? Yes. So I just wanted to say that in the case of Poland, we have sort of European bodies that are looking into what's happening in Poland. And Poland also has been threatening to leave the EU for a while. But I'm just going to read something to you. It says, since the ruling took effect on January 27th, 2021, this is what amounts to the near total abortion ban. 1,000 women have turned to the European Court of Human Rights in an effort to vindicate their rights, challenging Poland's highly restrictive abortion law and seeking justice. These groundbreaking cases mark the first direct challenges to be filed before the European Court. And then it goes on to say that the 9 leading international human rights organizations have filed third-party interventions to the European Court of Human Rights in these cases, and it goes on to list them. So it's Amnesty International, et cetera, et cetera. The problem is that, well, there are many problems, but the problem is that states that restrict abortion rights in the way that we've been speaking about them, they actually don't move against NGOs and grassroots groups because they know that they provide this release valve. And they don't directly criminalize the women. And so they haven't done that so for example, Texas So it's criminalizing people who aid the women who are seeking abortions. So it becomes complicated, but there should be some supranational organizations that tackle this. And I'm asking at the end of this paper to build into the DNA of law and medicine some kind of cross-border action, not just in helping women get across borders, but in also being able to access healthcare systems in other states. But I'm not a lawyer, and I don't know how that can be done.
I don't know if this is on. Lawyers does it take to make the links work? Is that good? Hello. I should add that I'm also not technically a lawyer yet. I really appreciate your question. I think my answer, I hope it doesn't come across as flippant, but if I can answer with another question, like what can international law do? You know, there's a lot of circumstances where international law doesn't really have any teeth. And especially for this kind of situation where it's emergent, it's urgent, this probably wouldn't be a priority for a lot of people right away. And so I think a lot of the responsibility has to fall within specific countries. And I think as with any international crisis, I think it's easy to say, oh, the international system will take care of it. And it just passes along a lot of responsibility where nothing will end up happening. So it is a good question. There are, you know, provisions and statutes that uphold women and uphold the rights of women. I honestly, I don't have much international law experience, so I don't really know what has been done historically, but I don't think much would come from the international sphere, which is maybe not a good answer, but I think that's where things are.
Yeah, there might be, I think part of this, my sense of this conference has been great in identifying future research ideas that really have to get done relatively quickly. That might be one. And then the other one, I'm going to pass to the mic, and then I have one last question maybe for you.
This is a fantastic panel, and congratulations. You're also nimble with the technological challenges. So really fantastically well done. I love tomorrow your question about what the role of international law is here. And Adam, I'd be very interested to hear your response to that question about the issue of vaccine equity in particular. What role do you see international law playing, and which parts of international law?
There we go. It's all tangled, so I'll just leave it on. Yeah, no, that's a really good question, and that's why I did close with a comment about the pandemic treaty, where I think there is potential for a mechanism like that, provided it actually has some enforceability and so on, to address some of these issues, and I'm glad that they've at least been raised in this context, not ruled out from the very beginning. But of course, we do get into the questions of who actually has the leverage in these sorts of conversations, things. And I'm also a bit skeptical that, looking at the timelines for the pandemic treaty, I mean, look how long it took to basically end up with a total nothing of a TRIPS waiver at the height of the pandemic on a very specific thing that followed on, very specific, guidelines within the WTO. If it took us that long to do that, with quite a sizable majority of WTO members being in favor, are we going to get something useful out of the pandemic treaty? That's a good question. And I know some folks in this room are more involved directly with that than I, so I'd be interested in following up with them. So possible, but I personally am a bit pessimistic.
Thanks. That was really interesting panel. And oops, and I'm about to really wreck the technology over here. I was just pondering after speaking to Susie Wiles, who was presenting on the New Zealand case study, and not yesterday, but just in a conversation with her, she had opined that, part of the problems with inequitable distribution of vaccines was also the rise of variant after variant after variant. And so her hypothesis was, look, if we had actually all closed our borders, had distributed the vaccines, that we may have foreclosed the development of endless variants. So short, sharp, sweet, equitable. I don't know enough about the science of SARS-CoV-2 to know, but at some point I'd really like to hear, perhaps this isn't quite the right panel, but from folks, is that true? And yeah.
Sure. Okay, now is this mic on? It is. Okay. I don't actually have a good answer to the particular like immunologic aspects of your question. And that was certainly that was a line of thinking very early on, obviously in the pandemic, is that, if we want to limit the number of variants of concern that emerged, then of course high vaccination coverage and so on. But whether that has panned out after we saw real world evidence or not, I think is frankly questionable. But what does remain clear is that the vaccines remain highly effective at preventing severe disease and hospitalization. And in spring of 2021, in many, many parts of the world, we saw health systems collapse. In Southern and Eastern Africa, we were working in Malawi and Mozambique, in Eswatini. We're also working in Yemen, where we were responding in India and so on. We saw very, very, very high caseloads that put extreme stress on health systems to the point of collapse. And the implications of that are that resources became redirected from other routine emergency and essential health services to respond to the COVID pandemic. And that meant, in particular, women's health services were severely compromised. We saw access to safe abortion care, comprehensive abortion care, and many, many other routine health services simply collapse. And we are now seeing regression, of course, in the global response to HIV, TB, malaria, breast cancer, the list goes on and on and on. And quite frankly, we're living that experience in Canada as well. So, I think the question of like, if we had had better vaccine equity, would we have gotten ahead of the variants of concern? I don't know. I mean, I think that the immunologists of the world are leaning towards no, but I'm not an immunologist, so I'm not going to speak for it. But certainly what we can say is that public health was severely compromised, and access to routine and life-saving health services was severely compromised because of inequity in vaccine access. And we were pushing very, very hard for emergency dose donations in spring of 2021 because we were on the front lines of it. We were seeing the impact of it. And the answer from most countries who were sitting on at least some surplus of doses at that time was no.
Last question.
Thank you. My question is for Nick and Adam, actually. Nick, it sounds like there needs to be some sort of reform to the
Jason.
Oh, pardon me. I'm sorry.
Nickerson.
My apologies. I'm very tired. Sounds like there needs to be some reform to the legal architecture to secure access for humanitarian workers. Could you envisage specific amendments, for instance, to the international health regulations to make an exception of that sort? I thought you were hinting at that. And if so, how would you designate what constitutes a humanitarian worker? And would you need the cooperation of nation states in order to secure transport, because you don't have your own kit for flying around? So that's my question to you. And Adam, my question for you is, I didn't call you Houston, by the way, so I hope that I'm starting off on the right foot. My question for you is, what you described sounds like almost like a prisoner's dilemma type scenario. You have these countries, they need to get vaccines for their populations, and you either cooperate with everybody else, like what's tried at the EU level, or you defect and you sort of go it alone. So are you suggesting that states should cooperate with one another at the beginning? If so, that there are huge barriers and risks to doing that. If you're outside a structure like the EU, if you're inside, even there are risks to it. Or are you making the case that there should be some sort of, each state should be able to go it alone, but then there are strict duties to ensure that there's equitable distribution of whatever comes out of it? Thank you.
I don't know that I've thought quite that big picture because people are smart enough not to put me in charge of the world. But I mean, there's some good questions there. I mean, for example, there's certainly within COVAX, who would really advocate for COVAX essentially to be adopted almost as is, maybe some slight modifications. And I mean, I think we've seen issues with that particular model, but nonetheless, the underlying idea, especially at the beginning where it was originally enough vaccines for 20% of the population, right? Let's make sure everybody's, your vulnerable populations, your health workers, which, to emphasize, if you're in a country that measures your physicians in like hundreds, as opposed to the 90,000 some odd in Canada, right? You lose a physician to COVID, the spillover, in the rest of your system is terrible. So, something like that, and we can tie that to, the state funding that went into the development of these vaccines, that sort of thing, stop caving to the pharma companies who finish it off. I think there is some potential there. I think if we were talking, all doses, for the whole population, I think that's going to be trickier, but something like that 20%, I'm almost optimistic that could happen.
Yeah, on the question of what's needed, so the world's going through this exercise right now of recognizing that there's restrictive measures related to counterterror laws, actually that have been implemented both by Security Council resolutions as well as domestically in many countries, that are placing an undue set of restrictions on humanitarian organizations. So Afghanistan is at the moment the sort of classic example where you have a government that is listed as a terrorist organization by many countries, including by the Canadian government, that's in power. So Canada is making the assertion that humanitarian organizations are unable to use Canadian government funding from global affairs to provide services in Afghanistan because you have to pay taxes, you have to, you have to interact with government services in a financial measure, and that would constitute, payments to a listed terrorist organization. So at the international level, there are Security Council resolutions from the past several years that are clear that domestic counterterror legislation can't impede directly or indirectly the work of humanitarian organizations. Most countries around the world have actually issued humanitarian exemptions to counterterror laws and so on. Canada is actually the only major country that hasn't found a way of doing this. So it's not an issue for us because we're privately funded, so we continue to work, but organizations have been very clear that they have been told by global affairs they're not allowed to use government funds, and so they've closed operations in Afghanistan. So the question of there's a sort of systematic reflection piece that seems to be missing from how governments are enacting some of these laws, right? Where we're sort of, I don't want to, we're a bit of an afterthought, right? We're like collateral damage in a sense of these very sweeping laws. Counterterrorism is necessarily sort of broad, it's opaque, it's quite nebulous, it captures a whole bunch of things almost unintentionally, and then governments go back and they sort of say, oh, well, not this, not that. And it was a bit the same with the Orders in Council in Canada, right? Where initially in March 2020, we saw these very, very restrictive border measures that basically said nobody except for Canadian citizens can come back. And then it got like, they said, okay, well, we need medical couriers to bring blood and we need all of these people. And so it expanded. That's not a very good way of legislating, right? And of regulating much of anything. And so, you know, what we really need is some sort of process that recognizes that, you know, there are restrictive measures that governments are going to bring in for a variety of different things. And what we're saying is that, you know, we need to be looking at sort of obvious things, right? Humanitarian organizations need to continue to travel and so on.
But
So I think the question was almost a new legal regime
Yeah.
to articulate this type of exceptions that should be part of any legal infrastructure that you're building, whether it's for terrorism or it's to respond to the pandemic. So I think we have to close, and I want to thank you for a fabulous and fascinating panel.